All right, I will maybe wait. Well, I guess I can wait just 1 or 2 more minutes and I can start, okay?
Sounds good.
All right, I'm going to start. I'm going to talk a little bit about left heart catheterization, left ventriculography, angiographic assessment of valvular disease with some examples. And I will also show some hemodynamic case discussion. Okay, so it will be kind of a mixed talk. So I'll start with this. And I'm showing in LV gram. And what do you see on that LV gram? I must tell you that the echo on this patient showed normal EF, no segmental wall motion abnormality. Anything interesting on that echo? On that LV gram, I mean? Let's see, let's pick Thor. What is interesting on that echo, on that LV gram? Do you see anything?
That's what I'm for here.
Huh? Yes.
To me, it looks like the basal segments of the heart are moving more than the apex.
It is true because the apex has a problem.
Yeah.
The apex is.
Oh, has a aneurysm there or?
Akinetic, dyskinetic.
Oh,
it's a slightly dyskinetic, definitely akinetic. So it's moving opposite to the rest because it's fully akinetic and it's being pushed paradoxically during systole. Okay, so there is apical akinesis with a slight dyskinesis that was missed on echo, which is not unusual because the very distal apex on echo is frequently missed or foreshortened on echo. And so they may cut through here on echo and they will miss the true apical abnormality. So it's not unusual. There is something else too here. Anybody, I don't know if someone else can see it.
I was thinking isn't like a aneurysm there or
no,
there's a clot?
Clot.
Thrombus.
There is a thrombus. I wouldn't call it aneurysm, just to tell you, aneurysm, just the difference between dyskinesis and aneurysm. Aneurysm means you have a bulging pocket both in systole and diastole. It bulges furthermore in systole, but it's bulging throughout systole and diastole. This one is not bulging in diastole. It only bulges when the remaining wall contracts and push it out. So it only bulges in systole. This is what we call dyskinesis. It's not severe dyskinesis in this case, it's mild dyskinesis, but it's not aneurysm, just to be clear. That said, it's still a very significant finding. It's indicative of an old apical infarct. Although dyskinesis per se may just be also ongoing ischemia. It does not have to be non-viable myocardium and infarct, or non-viable infarct, myocardium and old infarct. It could be also acute ischemia. We see it. It could be reversible. I don't think it is in this case because it's clearly chronic and you see apical thrombus. That's the important finding here. That was totally missed on echo. This patient had a distally occluded LAD with absolutely no collateral. In retrospect, this territory is an indication in this particular patient of an old infarct with non-viable myocardium. But again, dyskinesis is not always a non-viable myocardium. Aneurysm is a non-viable myocardium, but dyskinesis doesn't have to be. It could be reversible. So I just wanted to show this is a value of an LV gram. So this is what an LV gram does. This was an RAO view of an LV gram. This is again the view of the heart in the chest. This is RAO and this is LAO. Very important to distinguish. RAO is looking in this direction and it shows you, and these are the LV wall. Remember, this is a 2D imaging. We're just seeing the edges. We don't see the edges of what's on the inside. So we only see the edges of the border of the heart shadow. So when you look in RAO view, you will see the anterior wall. You won't see the septum because the septum is lower than the anterior wall. You see the anterior wall as a superior edge. You see the apex very well, and that's the best thing about RAO view, the apex. It's actually even better than echo. That's about the only place where LV gram is better than echo, apex. You also see the inferior diaphragmatic wall. This is RCA, this is LAD. You do not see too well the septum. You do not see well what we call the posterolateral, that area hidden in the back of the heart, the circumflex area, you do not see it. So you see well LAD and PDA specifically, LAD and PDA. I had in my interventional board recertification, they showed me an LV gram with an, dyskinetic inferior wall, and they wanted me to identify which artery. It's the PDA specifically. It's not PLB. So PLB and circumflex are not well seen. Septum is not very well seen. So this is what RAO does. It splits ventricular area and atrial area, okay? If you have a VSD, you're not going to see it well because, or you will see something, but it's hard to see it well because this view superimposes RV and LV, okay? Now, LAO, on the other hand, it looks in this direction. It's like the apical fourth chamber in echo. So you split left and right. You can see the left ventricle on one side, right ventricle. Of course, we don't normally see the right ventricle when we're injecting the left, but you can see the shadow of it, okay? Another note in RAO view, it's not important, but what you see mostly is the posterior mitral leaflet, which from this particular angle engulfs the anterior leaflet, okay? So this is an LAO view. So this was an RAO, this is an LAO view. This is an LAO straight. The problem, LAO straight is not great. It kind of overlaps a lot of things. It overlaps the septum with the apex and the anterior wall, but it does show the lateral wall. So LAO view, unlike RAO, it will show you that posterolateral circumflex infarct. Somebody's having an acute circumflex infarct and you do an LV gram, you may miss that posterolateral akinesis. LAO view will show it. We don't do LAO view routinely, but I just want you to be aware of that. Now, in order to improve LAO view, if you look from here, you will overlap septum and anterior wall. But if you look LAO from above, then you get the best spread of the LV, septum, and lateral wall. And the best spread also of the RV, should you happen to have a communication between the LV and the RV. Okay? It also opens very well the LA, the LV, LA. Unlike the LAO straight view, which can overlap LV, LA. That's again important in case you're having MR. This will be important in case you have VSD, VSR, ventricular septal rupture, okay? It's a classic board question that they will show you an LV gram with filling of the right ventricle, and that will be a VSD. It's harder to identify that on an RAO view. I do want you to know that we don't do those very often here, but you will use them in EP a lot. You will use that swinging between LAO, RAO, and EP. You just need to understand what ventricle you're looking at and what chamber you're looking at. So this is an example. This is an LV gram in an RAO view. And you see here a retrograde filling. It's not a playing image. It's not a film, but still you can see the delineation of a huge left atrium. Okay, so this is indicative of, as you can imagine, severe mitral regurgitation. Okay, now there is a technique to prove mitral regurgitation. I want to tell you that you need to know, or even though we don't talk much about it, left ventriculogram is an excellent modality to assess regurgitant valvular disease, particularly cases that are indeterminate by echo. It's because it is a volumetric assessment. It's a qualitative, but it's volumetric assessment. Unlike echo, which assesses Doppler, which can fade if it is an eccentric Doppler flow, it can fade and you can underestimate the significance of a regurgitation by echo. By LV-gram, you know, you're less likely to have that, because even if you have an eccentric flow, it doesn't matter because it's a volumetric assessment. Qualitative, but volumetric. You have to do it properly. So I'm going to give you a hint about how to do an LV-gram when you're suspecting MR and how to do an aortogram when you're suspecting AI, and then get your best answer. So one, in order to do it properly, or before I tell you that, I'm just going to give you the criteria of what we call severe MR by LV-gram, okay? Anybody knows what's, how do we call it severe MR by LV-gram? Maybe a second year fellow?
So the filling of the left atrium will be more dense than the LV.
Okay, that's a very important idea. So yes, the filling of the left atrium will be at least as dense as the LV, okay? So there are 4 grades, 1+ to 4+. 1+ is you just see a whiff of contrast. 2+, you see contrast filling the LA, but it's not equal to the LV. 3+, the LA fills fully and it is equal in filling to the LV. 4+, the LA fills stronger than the LV. I have it here, okay? So 4+, the LA fills more strongly than the LV, or it fills within 1 cardiac cycle as strong as the LV. So it's either fills more than the LV or as strong as the LV, but very quickly within 1 cardiac cycle. Or you see the pulmonary veins. This is 4+. But by the way, severe MR is a 3+. 4+ is very severe MR. So the surgical indication is a 3+ when the LA is as fully opacified as the LV. Okay. Now there is a catch though when we're doing this. That what I'm saying indicates that one, you need very good filling. You need very good filling of the LV. You need very good filling of the LA. And keep in mind, in patients with severe MR, you may have a huge LA. Okay, so in order to fill it, you have to give a large volume of contrast. Okay, that's 1. 2, you need to open the LA. When what you see in the standard REO view, you see the ascending aorta and the descending aorta is normally here in a normal REO view. So ascending and descending here. So the descending aorta is overlapped with the LA normally. So it will be hard to it will be hard to describe how opacified the LA is because the descending aorta is overlapped with it. So here are the technical hints to get a good LV-gram. You need to do a steep REO. So regular REO will get you here. The REO that we do normally is 30 degrees. The descending aorta will be here. So you do more extreme REO, something like 50, like I say here, 50, 60 degrees. And then the descending aorta will be spread out further away. You see in this image, I don't see the descending aorta, or you see it here. This is the catheter and the descending aorta, femoral axis. So the descending aorta is spread out in a way that you see the full extent of the LA and you can assess your MR. So that's one hint. The second hint is to give a big injection. Normally for left ventriculogram, I don't know if you know how much we inject. Normally I don't inject much. Depending on the size of the left ventricle, I can inject a total volume of anywhere between 18 to 30 milliliters. So not much of a volume. But when I have MR, you almost have to double it. I typically give something like 50 milliliters total volume, 13 milliliters per second. So I give a big and sustained volume to allow me to see that filling of the left atrium. Okay. One other caveat to keep in mind with this classification, when the LA is, you may have stages where the LA is bigger than the LV. And in those cases, it's very hard to have a 4+. It's very hard to have an LA more dense than the LV, simply because it's larger in size than the LV. So even if you have equal regurgitant volume, even if you have a 50% regurgitant volume, it will be diluted in a bigger chamber. So that contrast, that 50% will be diluted in a bigger chamber, so it will be less opacified than the LV. So keep that in mind. When you have a very big LA, it could be severe with maybe a little less opacification of the LA than the LV when you have a picture like this. So keep that in mind. So in this view, you can see the MR is severe. One, the LA is a huge, but that's not enough to define, of course, severe MR. It supports it. The other important thing you see is that they are opacified equally, despite the fact that the LA is bigger than the LV. That gives you an extra point in a way, because again, like I said, it's harder to opacify an LA that's bigger than the LV. Another thing is you see the left upper pulmonary vein filling here, and that's an indicator of a 4+. Okay, so those are some ideas. Another thing, general idea with all LV-gram, you want the catheter to be properly positioned. You don't want the catheter to be stuck. When we're entering the LV through the aorta, the catheter may get stuck in the papillary muscles and chordae. You should never inject when the catheter is stuck there. One, you can perforate the ventricle. Two, you create a fake MR because you're injecting all your volume in the chordae. So you should never do that, and you're not going to get a good LV-gram. So you may have to make sure your catheter is free, and it's normally in the middle of the LV cavity. Okay, so those are general hints. Another idea is you have to avoid ectopy. So it has to be in the middle of the cavity, free, not in the base, stuck in the chordae, not in the apex where you get a lot of ectopy. I'm going to give you another case. Does anybody have questions about this? All right. I'm going to give you another case. This is a 48-year-old man. He's referred for chest pain. He has had murmur for decades. On exam, he has a loud mid-systolic murmur and a hollow diastolic murmur at the left and right upper sternal border with attenuated A2. So mid-systolic and hollow diastolic murmur. Blood pressure is 150/70, pulse is 60. Echo shows a bicuspid aortic valve with eccentric AI that is read as moderate with mild AS. LV is mildly dilated, EF is 45%, and the aortic sinuses are dilated at 4.4 centimeters. So what is the next step here? I want to give you a few hints here. One, when you hear hollow diastolic murmur, what does this suggest?
MR.
Severity of the
RTI.
AI.
No, it's hollow diastolic.
AI.
AI. But what else does it suggest about that AI?
So if it's hollow diastolic, it means that it's probably severe.
Yes. It's a very important. It's not how loud it is necessarily, but it's when it is hollow diastolic. Whenever you hear that term, it is highly specific for severe AI, severe chronic AI. Normally in acute AI, it's not hollow diastolic simply because you get equalization of pressure between aorta and LV in mid-diastole. So in acute AI, you may not get hollow diastolic. In acute severe AI, it may not be hollow diastolic. But in chronic severe AI, it is a hollow diastolic murmur. And the finding of this is highly specific for severe AI. So whenever you hear that, be highly suspicious of severe AI and worry that the echo may have missed something. Another thing, the pulse pressure is wide. In a 48-year-old man, pulse pressure is wide, meaning one simple definition is the systolic pressure more than double the pulse pressure. Okay, the pulse pressure here is, or I apologize, I mean the pulse pressure is more than half the systolic. So the pulse pressure is 80. It's more than half the systolic pressure, 150. So this patient has a wide pulse pressure at the age of 48. It makes no sense. That's another hint. Another hint is that echo frequently underestimate eccentric jet, whether AI or MR. You also have other hints. The LV is dilated, EF is low, not clearly why. So that all that fit. So this is a great case to do an aortogram here. And this is the aortogram that we did. So again, this is not LV-gram, this is aortogram, but so, and here I want you to notice this. One, you're seeing the LV, it's the same classification as MR, okay, except here we're comparing the aorta to the receiving chamber, the LV. So what you can see here, you see the ventricle filling as much as the aorta. Don't look at the cusp. Our catheter, a pigtail catheter, is stuck in the cusp here. So that area will be more dense than the rest. But look at the aorta and compare it to the ascending aorta and compare it to the ventricle. The left ventricle is at least as dense as the ascending aorta. Importantly, it fills within 1 beat. If you look at it again, it fills within 1 beat, so it fills very quickly. For those two features, filling quickly within 1 beat and as dense as the ascending aorta, probably a little more dense, that's at least a 3+ aortic insufficiency. So that's severe AI, okay? Another hint here, or another technical aspect, when you're doing this, you want to do your injection. What view is this, by the way? Anybody can tell?
It looks like AB or shallow REO.
Yes, it's close to AP, but it is more of an LAO view. It's shallow LAO, but it is an LAO view. What it is, because remember, REO, in REO, your aorta will be here, and the aorta in REO is here, and then the aortic arch is there, and you have a descending aorta this side, like here, aorta, then descending aorta, ascending aorta and descending aorta. Whereas in LAO, which is the view we use to engage the coronary, you have descending is here, ascending is there. So this is an LAO view. And the reason, usually for aortic insufficiency, I use LAO view. The reason I want to see the whole aorta spread out, okay? And I want to be able to measure that ascending aorta, which I did, by the way. Remember, AI is frequently associated with ascending aortic dilatation. It could be the cause of it, or it frequently is the result of it, or it could be just a perpetrator of it. Regardless, I like to see that ascending aorta. I don't want it to be potentially overlap with the descending aorta. So I like to open it, and I like to do an LAO view. So for AI, particularly for that ascending aorta, I usually do LAO view, okay? So that's one hint. Now the volume for AI, same thing. You have to inject a big volume and sustain it. And it has to be, you're filling the aorta. It has to be an even bigger volume than what you do with MR. So what I do here, I usually do 50 to 60 milliliters of contrast, and I use 20 milliliters per second. So 20 milliliters per second for a total of 50 to 60 milliliters. You have to fill those structures to be able to compare them. Keep in mind, those structures are dilated, so you need a big volume to fill them. The more dilated the structure, the bigger volume you need to fill them. This is the same with MR. Again, but MR, the number was slower, 13 milliliters per second for a total of 50 milliliters. So keep those numbers in mind, very important for when you do those, okay? Another thing to notice here, this is bicuspid valve. Interestingly here, this is again LAO view. So normally you see right cusp and left cusp. Interestingly here, the jet, those right and left cusp are stuck together. There is nothing moving here. You see the right and left curvature. It's hard for you to appreciate, but the jet is coming more posteriorly. This right and left cusp are fused, and the jet is coming posteriorly from the non-coronary cusp, between the non-coronary and that fused cusp. So those two cusps are fused. And it's mostly that right portion of that cusp that is dilated. It measured 4 centimeter by aortography. Okay. So those are some of the hints. Any questions? All right, I want to explain quickly how to access the left ventricle. So one technique to access the left ventricle, even though I image frequently in RAO, I like to access the left ventricle in LAO, simply because LAO spreads out the right and left cusp, and behind them the non-coronary cusp. There are two major techniques. One technique is to use the pigtail catheter and use the pigtail itself to fall in the left ventricle. I usually advance a pigtail, I put a wire in it all the way, not out, but all the way to the tip to stiffen it, and I try to make it loop. And when it loops, I hope it will fall. The technical hint here is don't loop it. The biggest issue is that sometimes and frequently it loops on that right cusp, which is the lower cusp, or the non-coronary cusp, and it gets stuck in it. You have to try to free it from that right cusp. So as you're pulling to loop it, maybe pull it back also, pull it up a little bit, just so it overlaps with the hole in between. That's one reason I like to use LAO view to engage, because it allows me to estimate where is the right and left cusp and to aim in between. So I try to loop it somewhat in between the right and left cusp, and at some point it will fall. That's the hope. Now, if it doesn't fall, you pull back and restart. And as you're pulling back, give it a slight clock or counterclock. Let's say, for you to make it simple, slight counterclock, and sometimes it will fall as you're pulling back. So that's one technique. Sometimes it falls halfway in, that arm falls in, but the tip is still in the aorta. This is very easy. If this happens, just advance the wire and the whole system will fall in. The other technique that I like, that we use more often these days, is not using the pigtail, is to just use a standard catheter. And that technique is particularly useful when you're not aiming to do an LV gram, you're using a Tiger catheter to access the LV and measure LVDP, or when you're accessing severe aortic stenosis, okay? So this is a standard catheter, typically, for example, a Judkins Wright catheter. You use that catheter. So when you're doing that technique, you have to access the left ventricle with the wire, not with the catheter. So when you're doing a pigtail, you try to access and loop and push the pigtail itself. But when you're using a standard catheter, you cross into the ventricle with a wire, then you track the catheter over the wire, okay? All you do with the catheter is direct it. You start torquing slightly the catheter and pulling it up to direct it into that hole between the left and right cusp. Then you push the wire and you track the catheter over it. So what you do, you direct, you push the wire. If the wire doesn't go, you pull it back, you give a slight torque to the catheter and maybe slight pull and push. You redirect and push the wire, then pull it back. So you keep redoing it. Torque the catheter, advance the wire, retorque the catheter, re-advance the wire until the wire gets in, okay? One mistake that we do commonly, especially from radial, where we have problems getting into the LV, is that our catheter is stuck in the right cusp and we keep advancing that wire into the right cusp and looping it in the right cusp. You have to try to free that catheter up and advance the wire in between the right and left cusp. So whenever you're struggling with accessing the left ventricle, it's oftentimes that you're looping low in the right or non-coronary cusp. You need to get up a little bit, free it, and re-advance. You try different catheter torques and heights. This is another example of various anatomies of the aortic cusp. Those are interesting because you're not seeing the aortic cusp, you're imagining it. So you need to kind of be able to imagine the anatomy. This is particularly relevant in aortic stenosis. And based on the anatomy of the ascending aorta and the anatomy of that cusp area, depending how straight, horizontal, or vertical it is, and most often it is close to number 3. In most elderly anatomy, your anatomy is mostly number 3. Your aorta is elongated and flat, and the cusps are vertical. So depending on that shape, you decide what catheter I use. Typically, frequently in Amplatz left is the best catheter to access the left ventricle in severe aortic stenosis or in those patients with elongated aorta. Amplatz left will sit here and will aim you to the hole in between the right and left cusp, okay? So I'll show you some examples here, okay? Normally, by the way, for non-AS cases, I use just a standard wire, J wire. For AS cases, we use a straight tip soft wire, but straight tip so that it can cross that. You don't want a J when you have severe AS, okay? So this is an example here of a patient with aortic stenosis, okay? So I tried to cross blindly for a couple of minutes, I couldn't. So in that case, I'm using an Amplatz left. A reminder, this is the catheter that has that big butt with a duck shape. So I'm using an Amplatz left, I couldn't cross. It's always important at this point to do an aortic root shot, not much contrast, 10 cc's, just to get an idea of the anatomy. So now I know the anatomy and I know the angle and I know where to aim to. So using this as my guide, so I put it as my guiding image as a reference, and now I start maneuvering with the wire using this as my guide. So look here. So I start aiming my wire, and you can see, and it went in, okay? So I'm aiming my wire to that area. At one point, it will loop in the right cusp. You'll see it here. Here I'm hitting, here I'm looping in the right cusp, then I went into it. But the idea is that I know the anatomy, so it wasn't hard. So after I got that wire in the left ventricle, I chased it, tracked the catheter over it in the left ventricle. Then we typically exchange for what we call a double lumen pigtail. Okay, so I put that catheter in, but that catheter is not great. It's very irritating. It pokes the ventricle and creates ectopy. So you have to exchange. So you advance this, then you advance the catheter. Then you put an exchange length J wire that is friendly to the ventricle. Then you exchange for another catheter, such as an exchange length pigtail catheter, such as, double lumen pigtail catheter to measure the LV aorta simultaneous gradient, okay? I'll skip that one. I want to give you a case, actually. I hope I will have time. It's a really very good case for you. So this is a 78-year-old man with a history of chronic hypertension, well controlled. He has been having mild exertional dyspnea for the last year, but he remains active and plays ping pong with more interruption than normal. On exam, he has it's concerning for severe AS. On echo, he has normal EF, poorly mobile and calcified aortic valve with a peak velocity of 3.2 and a mean gradient of 23. Aortic valve area is calculated as 1.5. Anybody can tell me, by the way, what is severe AS on exam? What's the single most important feature to say severe AS on exam?
Absent S2.
Absent A2, yes. Absent aortic component of S2, or mainly absent S2 at the right upper sternal border and the apex and lower left sternal border. You may still hear a P2 at the left upper sternal border, but absent A2, or it may not be absent. In this particular patient, it was not absent, but it was very attenuated, okay? So keep that in mind. Actually, it's a board question. If you have normal S2 split, that rules out severe AS. That's a board question. Normal S2 split rules out severe AS. All right. So another physical exam finding is what we call the pulsus parvus and tardus, the late peaking carotid pulses. But that may not be true in an older person who has non-compliant arteries. Your pulse may still be robust and brisk, even with severe AS. So the most important thing is attenuated, severely attenuated A2. So I looked at his echo, okay? So this is his aortic valve velocity, and this is the LVOT velocity. And I want to highlight two caveats here. This is the 5-chamber view. And look at aortic valve velocity. It measured 3.2, maybe more, 3.4, 3.5. But there is a big problem. The biggest problem with echo and AS is misalignment with the flow. That the cursor is not going with the flow. It's almost 45-degree angle with the flow. So this is missing the true velocity. Whenever it's not aligned, you're missing the true velocity. And that's the biggest catch of echo and AS. Another problem that they had in aortic valve calculation, this is the LVOT velocity. They measured it as 1.6. And so they came out 1.6 and 3.2. The dimensionless index is 0.5. So they calculated it as, you know, barely moderate AS. But they made a mistake. Whenever you want to assess severe AS, you want to assess the LVOT velocity. The LVOT cursor should not be in the aliasing area of the aortic stenosis. You should be far from the aortic stenosis complex. They put their cursor around here to get 1.6. You should put your cursor away from the aliasing. This is not LVOT velocity. This is part of the aortic stenosis complex. You do get LVOT acceleration on your way to the aortic acceleration. You should not put your cursor in the aliasing high velocity LVOT. You should put your cursor a little lower. So when you put it a little lower, this is the true LVOT velocity. And now you have a low dimensionless index of about 0.25. But this is the one they used. So keep that in mind. So that echo has two caveats. Aortic velocity and gradient was incorrect, and the LVOT velocity was incorrect. A third caveat that you can get is mismeasurement of the LVOT diameter. Underestimating, measure it as too low compared to what it truly is. Underestimating that LVOT diameter by about 15% on average. So I did hemodynamic measurements on him, okay? So this is the simultaneous LV aortic pressure measurement. Okay, this is the scale 100, 200. And so I want to see, what do you think is the gradient here? Anybody can tell? If you look at this quickly, what's the gradient? Or what gradient can you assess looking quickly at this?
You can see the peak to peak is about 40.
Yes, peak to peak is every box is 20. So peak to peak, I would say close to 30. You have 1.5 boxes, okay? This is one box is 20. This other box is about 10, okay? We measured it as 28, okay? So there is peak to peak gradient at 28. But here I want to highlight for the newer fellows, I do want everybody to know, this is an important picture for you to memorize, okay? This is the aortic pressure, this is the LV pressure. There are 3 types of gradients, okay? There is the mean gradient, which traces the area in between, okay? And it's an integral of every instantaneous gradient, and it's average throughout systole. That's the mean gradient. Then you have what we call peak to peak, which is something we can only obtain by cath, which is the highest point of each compared to each other. Then you have that green thing, which is the peak instantaneous gradient, which is the point in time where you have the absolutely highest gradient, which is what you get by echo. By echo, you get that peak instantaneous gradient, which is the high velocity here. This is the peak instantaneous gradient. This is the peak instantaneous gradient, the highest velocity. The mean gradient is when you trace that, which we can also get by cath. So this is mean gradient, and you can get it also by tracing on echo. This is the peak instantaneous gradient, which is the peak velocity, corresponds to the peak velocity on echo. And this is the peak-to-peak gradient, which we only get by cath. The peak-to-peak gradient is the one we like most by cath because our eyes immediately grab it. You need to know the correlation between all those numbers. By echo, I hope everybody who's done echo knows that the peak instantaneous gradient is higher than the mean. But what's the relation between mean and peak instantaneous gradient? Does anybody know? Compare the mean gradient to the peak instantaneous gradient. What's the correlation?
The mean gradient is 0.7 times the peak instantaneous gradient.
Yes, close to that. The mean gradient is about 2/3 of the peak instantaneous gradient. 2/3 to 70% of the peak instantaneous gradient. Good answer. How about the peak-to-peak gradient compared to the mean gradient? I want you
similar.
Exactly, very good answer. They are almost similar. Keep that in mind. So peak-to-peak is not peak instantaneous, it's different. Peak-to-peak is almost equal to the mean gradient. That's important because now we see this simultaneous gradient. Now we have to measure the valve area. Okay, so I'm going to give you more number. Cardiac output is 4.4, cardiac index is 2.33. So what is the valve area here? Can anybody do quick math? I want to highlight, while you're thinking of that, I want to highlight a couple of technical issues you can encounter. Dr. Rosen mentioned those, so I will not elaborate on those. Sorry. Yeah, anybody was asking or saying?
Just calculated the valve area, probably 0.9.
Very good, very good. Who's this? Sorry. Very good. Huh? Good, excellent. You are correct. But let me, very good. I'll explain that and I'll explain a couple of technical points. When you're doing simultaneous LV aorta, you have to make sure we're using 2 pressure transducers. You have to make sure both those pressure transducers are 0 at the same level. Okay, you have to ensure that none of them has what we call transducer drift. Okay, none of them has a 0 drift in a sense that creates a false gradient or attenuates the gradient. Another thing you do, I always swap transducers. So this one was obtained with transducer 1 in the LV, transducer 2 in the aorta, and here I swapped the lines. So transducer 2 in the LV, 1 is in the aorta. I ensure obtaining the exact same gradient. So that's how I ensure that my measurements are correct. Another thing that can happen, one chamber can have more damping than the other chamber. And that can also, if that chamber, imagine that aorta is very damped, that aorta will go down. That will create a false gradient. So you want to ensure both chambers are properly damped, not too damped, certainly not too damped. So you have to ensure proper damping of both chambers. And one thing to do, if you have a not so good damping of one chamber, then when you swap, you will realize your error. So it's always important to swap both transducers and ensure you get the proper gradient. Then at the end of your recording, it's important to pull back and see, here I have 2 tracing, not 1, but they are exactly superimposed. You cannot tell that there are 2 tracing. So you have to, when you pull back the catheter at the end, both holes of that double lumen pigtail are in the aorta, and you have to ensure that when they are both in the aorta, they have to be both exactly superimposed. That's how you verify you did proper measurements. Okay, I go back to the mental calculation of the aortic valve area. Unfortunately, I don't have time to go over it. Dr. Rosen did go over it at some point earlier. There is this thing called the Gorlin equation, which you need to memorize well. It's a flow across the valve divided by square root of mean gradient and a constant. So it's a flow, that's easy. Remember it like this, flow divided by square root of mean gradient. Now I always tell fellows, what is the flow across the aortic valve? If you have a cardiac output of 5, let me ask here, first year fellow, Arouj, if you have a cardiac output of 5 liters per minute, what is the flow across the aortic valve?
So it's 5 liters in 1 minute. So flow would be per beat.
You're close. So the flow, you're close kind of. Yes. So the idea is that 5 liters per minute is crossing the aortic valve not in 1 minute. It's only crossing the aortic valve during systole. So it's actually, if you want to measure the flow rate, it's 5 liters, and let's say the systole in this patient is 25 seconds. You have 25 seconds of systole, 35 seconds of diastole. So that 5 liters is crossing the aortic valve in 25 seconds. So it's actually 5 liters. So the flow across the valve is 5 liters per 25 seconds. Okay. So it is 0.2 liters per second. That's the flow across the valve, 0.2 liters per second. You got it? So it's 5 liters per 25 seconds, not 5 liters per minute. Everybody understood that? It's a very important point. So that's why this is where the more complicated equation comes. But just remember that simple complex. Flow divided by square root of mean gradient. Flow is actually cardiac output divided by second per time, that is systole, okay? And then you come with a more complex equation. Well, what is the systolic time? That 25 seconds is what? Is actually how much time you have in every systole. Let's say it's every systole is X amount of milliseconds multiplied by the heart rate. So this is where that complex equation comes. It's cardiac output divided by the systolic time, which is heart rate by the systolic time of every beat. Then you add 1,000 to adjust for the units and the constant. Now it's been shown that, interestingly, the 1,000 and those are often equal to each other when you have a heart rate of 60 to 100. So this is where the Hakki equation comes, where he came up with that valve area is actually not just a flow divided by square root of mean gradient. When you account for the constant and the other variable of the flow that we discussed, actually valve area is cardiac output divided by square root of mean gradient. So that's even the simpler equation, but that's the better one. Flow divided by square root of mean gradient is the better one than cardiac output divided by square root of mean gradient. But I like that one because it allows me to make a quick math. So in the cath lab, we can make a quick math while I'm doing the procedure. Before scrubbing out, I plug in the cardiac output and I plug in, you don't have to use mean gradient. You can use peak-to-peak gradient as a surrogate because, like I said, they are usually approximately equal within a few millimeters of each other. So in that patient, when I plug it, it is cardiac output was here. So cardiac output was 4.4 and peak-to-peak gradient was 28. So you measure it, 4.4 divided by square root of 28, which is about 5.5. So I came up, like you did come up with 0.9 as a quick mental math. Interestingly, we did eventually the more sophisticated calculation using Gorlin equation. We used the diastolic, we used the systolic time, heart rate by systolic ejection period and the constant and all this. We came up with the exact same number, 0.9 centimeters squared. All right, so now we have all the math on this patient. Now we haven't answered the important question. Unfortunately, it's 8. I can keep going, but I think you may have other duties. Do you want me to keep going for, it will probably take me 5 to 10 minutes. Do you want me to keep going? Is it? I guess I can keep going for whoever is here for about 10 minutes and, okay. So now the bigger question. So we did the cath to avoid the shortcomings of echo. So here's what we have: aortic valve area 0.9, mean gradient 27.5, and cardiac output 4.4. Is this AS severe? That's the question. That's why we did this case. Is it severe? Can anybody tell me, is it severe or not?
Severe based on the valve area.
Okay. Well, how about the gradient? Why is the gradient low?
I wonder if it's like a low flow situation. Even the cardiac output is low, but the index is 2.3, so could be a low flow, low gradient type situation.
Could be low flow, low gradient, except the flow is not that low. And if you calculate the stroke volume index, you know, by dividing cardiac index divided by heart rate, it came up, actually, I measured it, 40 milliliter per meter square. It's cardiac index divided by pulse of 60. So using the definition of low flow is 35 milliliter per meter square. It's not low flow using that definition. So why is the gradient low?
Well,
I'll go back to that equation. But before I say that, is it severe or not? Before I dive into more details.
So I think it's severe because
Yes.
I don't remember the formula, but when we calculate with severe AS, the valve area has to be 0.8 for mean gradient to be greater than 40.
Excellent, excellent. Very good point. I think you got the answer I was looking for regarding flow. Very good answer. Excellent. So here's the thing. By cath is different than echo. If I have those numbers by echo, okay, you need to realize when you have those numbers, 0.9 and 27.5 by echo, half the time it is not severe AS, it's moderate AS, that with miscalculation of the valve area, half the time, okay? Because the valve area, for a variety of reasons, most importantly, LVOT diameter, LVOT diameter is frequently underestimated by echo by about 15%. So you mismeasure the valve area by echo. So half the time it's mismeasurement. The other half, it's truly severe AS. And it could be truly severe AS with a falsely mismeasured gradient by echo. They miss the real gradient, like in that particular case that I just showed the angles. Or it could be truly severe AS that is related to low flow state, okay? With normal EF. All this I'm discussing is a normal EF situation, okay? So again, if it was echo, I wouldn't be sure it's severe AS. I would say 50% it's wrong, it's not severe AS. But since when you obtain it by cath, then that's it, you're definite. That valve area is real. As long as you've done careful measurement, like I explained, that valve area is a real valve area. This is a truly severe AS with a low gradient. Now then you assess, why is the gradient low? Again, EF is normal. So Arouj mentioned a very important point. I'll go to it in 1 second. But I will go to that equation. That equation explains everything. Again, the Gorlin equation, valve area flow divided by square root of pressure gradient, which tells you that that pressure gradient here is very susceptible to flow. It's sensitive to flow square for a fixed valve area. When the flow doubles, the pressure gradient will quadruple. So imagine how dramatic, if flow goes from 3 to 6 liters a minute, your pressure gradient will quadruple. So that equation is very sensitive to flow, okay? So one explanation of having a low gradient is having a low flow. But there is another explanation that we don't often talk about, and this is what Arouj described. Plug this Hakki equation, okay? Valve area, cardiac output, square root of pressure gradient. For a valve area of 1, okay, and a cardiac output of 5.5, what would the pressure gradient be? The pressure gradient for a valve area of 1 and a cardiac output of 5.5 is 27.5, if you make the math. So this is a very important idea. A good proportion of those low gradient, truly severe AS are due, so some of them are due to truly low cardiac output and low flow across the valve, but a good proportion are due to what we call misalignment in the guidelines, misalignment between the aortic valve area and gradient cutoff. Meaning the guidelines use an aortic valve area cutoff of 1 centimeter square to define severe AS, and they use a mean gradient of 40 to define severe AS. In truth, 1 centimeter square corresponds to kind of 30-ish millimeter of mercury gradient, while a 40 millimeter gradient corresponds to 0.8 centimeter square valve area. So the gradient are misaligned, but I don't disapprove of that. I actually like the idea because the gradient want to pick the more specific pressure gradient. If your pressure gradient is over 40 on echo, you almost 100% have severe AS. So they picked a gradient that is very specific, where you have unquestionable severe AS. Conversely, if by echo you have a gradient of 30s, it's not always severe AS. So they picked the gradient that is cut off that's very specific, and they picked an aortic valve area that by echo is sensitive, not very specific, okay? By cath, on the other hand, the valve area becomes very specific because you measured it accurately. So when you get it by cath, even when you have this, this is definitely severe AS. Severe AS with either low gradient or with either low flow or normal flow, but low gradient because of that misalignment in the guidelines, meaning normal flow and a valve area of 0.9 or 1 will be a gradient in the 30s. Unless you hit 0.8, you may not get a gradient of 40. You kind of got that idea? So I will mention one more. So what's the next step? So, okay, we made the we did the catheter measurement. We have that low valve area. What's the next step? Dobutamine study, exercise, nipride, valve calcium score, or TAVR? Or a surgical AVR? Anybody will pick? What will you do next?
Dr. Hanna, was the patient having symptoms? You mentioned he was
Yes,
short of
dyspnea, class 2. Class 2 dyspnea, yes.
So if it's symptomatic severe AS, they should proceed with TAVR or SAVR.
All right, how about dobutamine study? Low gradient with aortic valve area less than 1. Should you do dobutamine study?
But you mentioned the stroke volume index is more than 35, so the dobutamine may not give additional information.
So yes, but that's not the answer I'm looking for. It's not because of the stroke volume. Even if the stroke volume was 30 milliliter per meter square. The idea I want to say here, the key point about dobutamine is normal EF. Even when you have low stroke volume, even when you have low flow, low gradient, severe AS, when you have normal EF, what's the cause of the low gradient when you have normal EF? What's the cause of the low flow when you have normal EF? The cause of the low flow is not low contractility. This is the normal EF. So low gradient AS with low EF, the issue here when you have low EF is contractility. This is wrong. The issue here is contractility. But when you have low gradient AS with normal EF, the issue is poor diastolic filling, low preload volume. You have a thick and concentric LV cavity that's not able to fill. You have high afterload from hypertension. Low preload, high afterload create low output in a patient with normal contractility. So whenever you have low gradient severe AS with normal EF, dobutamine is not the answer. The answer, so you should not do it because the issue is not contractility. If anything, dobutamine may worsen your gradient, may lessen your gradient, simply because with dobutamine, you drop the preload. You have less time for diastolic filling. And then somebody who's preload dependent, you'll actually drop the preload. And if anything, you may worsen the flow and the gradient. So keep that in mind. That's a common mistake. Do not do dobutamine study in normal EF. It's not even validated. If anything, if you want to do something, to improve cardiac flow, You want to do something that improves cardiac flow in somebody with impaired diastolic filling. You can do exercise, which increases venous return. You can do nipride, which reduces afterload, which is an issue in those patients. So you improve preload, which is low, and afterload, which is high. Those are the determinant of low flow in those patients. So this is if you need to do something, and this is still debatable. One group in Spain does exercise. Mayo Clinic have studied nipride. It's questionable. I'm not saying to do it, but if you want to do something, do those, not dobutamine. What we do classically when I prove it by cath is I just send them for a valve replacement. Another thing to do that's well validated in those is aortic valve calcium score. You can do that when you haven't proved it by cath. If you have those numbers by echo and you don't want to do cath to prove it, you can do calcium score of the aortic valve. A score over 2,000 in men, 1,200 in women has been validated as highly specific for severe AS in this context. So you got the idea here, okay? So low gradient AS with normal EF, 3 types. This is a summary. Echo mismeasurement, hence the importance of cath or other modality to confirm, such as CT calcium score of the aortic valve. The second possibility is low gradient true AS with low flow because related to low preload, high afterload, filling, loading conditions, not contractility issues. The third option is low gradient true AS with normal flow related to misalignment of the guidelines, as is the case in our patient. This is different from low gradient with low EF, where you actually do, and the board answer is to do dobutamine study in those cases to prove severe AS. We can show you a case in another setting about the low gradient with low EF. I went over all this. Any questions, technical issues, anything? We stayed a little later, but any questions? It's an interesting topic. I can stay for a few minutes for those who have questions regarding this topic.
This was really great, Dr. Hanna.
Or any technical issues with aortic valve, aortic LV gradient measurement. Dr. Rossen highlighted it very nicely in one prior lecture, so I didn't go over it. Maybe since a lot of you are still here, I will explain another point, how to measure LV aortic gradient. I described, so one way of measuring it is having a double lumen pigtail, basically a pigtail that has 2 catheter side by side, 2 catheter attached to each other. One catheter finishes in the LV and another catheter tip finishes in the aorta. One issue with that catheter is that you get nice LV tracing because the pigtail has multi-holes. It's not damped. You get a nice tracing, but the aortic tracing tends to be damped. So you can create a problem when you do double lumen. The LV is nice, but the aorta is can be damped. And so that can create a false gradient, okay? So that's one issue with that catheter. And you can discover that issue by swapping transducers. When you swap transducer LV aorta, then you can notice that issue. The gradient may change. So always remember to swap transducer and always remember to verify the proper damping on pullback. If they are not properly damped, then when you pull back, the aortic lumen will be more damped than the LV lumen. So you'll have aortic tracings that are not superimposed. Another way of measuring simultaneous LV aorta is to put one catheter, a 4 French catheter in the left ventricle and a 6 French sheath, rather than putting it in the groin, make that sheath long, 55 centimeter, and lend it all the way up almost in the aortic arch. So you have almost an aortic arch, aortic pressure, and an LV pressure. That will give you 6 French sheath in the aortic arch and a 4 French in the LV. that the gap between 6 French and 4 French allows you to have a very good aortic pressure measurement. And the 4 French LV catheter gives you a good LV measurement. So that's the modality that I like as well. The caveat you need to do it from the groin in order to do that. Okay, so those are the 2 ways of doing it. You don't want to do a femoral sheath or radial sheath and LV simply because the femoral sheath and radial pressure are not always superimposed with the aortic pressure. They tend to be amplified. So the radial pressure is actually often higher than the aortic pressure. It peaks higher, and that can attenuate the gradient. Besides the fact that it's usually delayed compared to the aortic pressure, it peaks higher. So we don't like to use radial pressure or femoral pressure. We like to use long sheath with aortic pressure. All right, I think that's it. If there are any questions for the fellows who are still here, any questions?
Yeah, Dr. Hanna, this is Fani. So now that we don't have the Langston catheter or it's on recall or something, is there another dual lumen catheter we can use?
No, but you can do, that's what I was just describing, which is a technique I like. The 2 where you put long sheath, the 6 French sheath in the almost at the aortic arch, and the 4 French LV. So one axis, you put a long 6 French sheath in the aortic arch, and you put inside it a 4 French pigtail catheter. So you measure the LV with the pigtail catheter, the 4 French, and you measure the aorta from the sheath, but that sheath is in the aorta. Because it's only, you have a 6 French sheath, but inside it you have a 4 French catheter, the gap between them is good enough to measure the pressure. Did you understand my point?
Yes, thank you.
Dr. Hanna, I had a question. So in this picture you said for Langston, the aortic, the catheter, can get damped.
Yes.
But how will changing the transducer help? Because even that's what I'm trying to understand. If you change the transducer,
you are correct. Actually, it probably wouldn't. It probably wouldn't. You are absolutely correct, because the issue is from the lumen itself. So swapping a transducer will not help.
Yeah.
Swapping the transducer will help though if you have if the damping is occurring beyond the catheter. Okay.
Yeah,
if the damping is occurring, 1 at the transducer level, 2 in the lines between the catheter and the transducer. So you remember, every transducer is connected, every catheter, every lumen is connected to a different line. So the line connecting the ventricle may be longer than the line connecting the aorta, or vice versa. Also, the line may be stiffer. The tubing that you're using may be different and stiffer. And that tubing, depending on its length and its stiffness, and or the presence of air bubble or clot or blood, all those can create different damping between the LV and aorta. However, you are correct that swapping the transducer will not correct the issue of the actual catheter itself. You are correct about that. It will correct a lot of other issues that we encounter. And those are the issues we encounter frequently: tubing length, air bubbles, stiffness, different stiffness of tubing, etc. You want to keep your tubing short, by the way, as short as possible when you're doing those measurements, and limit the number of stopcocks. You know, the more you add things, the more you damp, the more you introduce errors. That's why this is the final step that proves what, if you do this and you've swapped the transducer, you've damped, you've corrected your tubing, you've swapped the transducer, obtained the same measurements, but yet when you pull back, they are not superimposed. The only thing you can do at this point is change your technique. Don't use Langston. Use what I described, those sheath and LV catheter. Or the ultimate technique is use double access. So you have radial access with LV catheter and femoral access with aortic catheter. So you get 2 separate accesses with each access for 1 cavity. This is the ultimate best measurement if you keep encountering issues with damping. But you have to first verify it. You have to know I'm damped. You have to identify the problem. And this is the ultimate correction, identification of the problem.
So I'm reading on Twitter that people are getting creative using FFR wire now for, the wire is in the LV and.
Yeah, that's one way of doing it as well. I don't necessarily like the FFR wire. It doesn't, it has also, remember, we want to obtain perfect measurements here. And it may have issues with damping too. And the FFR wire, they are better now, but they do tend to have a lot of transducer drift. If you stay a long time making multiple measurements, you may have issues with transducer drift, meaning you may create false gradient or attenuate gradient. It's not wrong. Another thing to keep in mind when using FFR wire is ectopy. You really want stable measurements. And when you're having a wire, flimsy wire, flopping around in the ventricle, you'll create ectopy. So there are issues with damping, drift, and ectopy when you're using FFR wire.
Thank you so much, Dr. Hanna.
Yeah, sure. Any other questions about low gradient and so on? All right, if nothing, then I thank you for staying so late. All right.
Thank you.
Thank you.